You know, in clinical practice, you're often presented with two clear paths to solve a problem. Let's take severe bone atrophy. For a long time, the choice was either go through a major bone augmentation procedure or, well, do nothing. But what if there's a third way? A path that kind of sidesteps the whole dilemma? That's exactly what we're diving into today. A really groundbreaking workflow in implantology that's carving out that new path. So, here's the core problem we're facing. For a patient with severe atrophy of the maxilla or mandible, what's the best move? You can't just place a simple implant, there's not enough bone. But on the other hand, major bone augmentation, that comes with its own set of serious challenges and risks for the patient. It really puts you in a tough spot and makes you wonder, right? There has to be a better way forward. And the answer is a resounding yes, there is. That third way is all about placing an implant directly into these compromised bone conditions without any augmentation. Sounds pretty radical, right? Well, in this explainer, we're going to break down the entire advanced workflow for what's called the maxilla/mandible individual implant, or Meyer implant for short. This is the technology that makes that third option a clinical reality, completely taking bone grafting out of the equation. Okay, so here's our game plan. First, we'll look at the clinical pathway and why this is so needed. Then, we'll get into the nuts and bolts, the digital blueprint, how these things are actually made, the all-important surface prep, and finally, what it all means in practice, the precision results. All right, let's start with section 1, a third clinical pathway. We're really going to dig into the problem we're trying to solve here, which is severe bone atrophy in the maxilla and mandible. So we're talking about a very specific group of patients here. Clinically, they fall into what's known as Coward and Howell classes V and VI. And to put it simply, that means the alveolar bone, the bone that holds the teeth, is almost completely gone. It's just resorbed away. For these patients, conventional implants are just not an option. And if you look back at how we've tried to tackle this in the past, well, the solutions have had some pretty major drawbacks. Let's take a quick look back. Way back in the 50s, we had these early subperiosteal implants, but they were prone to infection and didn't integrate well at all. Then you have the option of massive bone grafting, which means harvesting bone from somewhere else on the patient's body, a really invasive surgery. Zygomatic implants are another route, and they're certainly viable, but they come with their own list of potential complications like sinusitis or soft tissue infections. So you can see how all of these limitations really set the stage for something new. The modern 3D printed titanium subperiosteal implant. It was basically born out of the need to solve these very problems. Okay, so now that we understand the why, let's get into the how. Section 2, the digital blueprint. This is where it all begins, moving from a patient scan to a custom implant design, all before anything physical is even created. So the workflow is really a 4-step dance. It all kicks off with a high-res CBCT scan from the patient. That data then goes to a bioengineer who does something called segmentation, basically digitally isolating the bone from all the other tissue to create this super precise 3D model. From there, the real design work begins. The implant mesh, where every single screw will go, the position of the multi-units, it's all custom designed right on that 3D model. And the final crucial step? They overlay that design with the prosthetic plan to make absolutely sure everything lines up perfectly for the final restoration. And this really shows you that transformation in action. On the left, you've got the raw data right out of the CBCT scanner. And on the right, that's the final product of all that digital work. It's a completely patient-specific implant framework designed to fit the patient's unique anatomy like a glove. All right, the digital work is done. Now for section 3, where we make this thing real. We're moving from the blueprint to the physical implant, which is built from medical-grade titanium using a really cool mix of manufacturing methods. The heart of this manufacturing process is a technology called selective laser melting, or SLM. You can think of it as a very, very precise form of 3D printing. A powerful laser literally melts and fuses titanium power together, building the implant layer by tiny layer. And when I say tiny, I mean it. Each layer is just 30 micrometers thick. That's how you get these incredibly complex custom shapes with such high precision. And here's what it looks like fresh off the printer. This My implant is still attached to the build plate of the SLM machine. It's in its raw form, but you can already see the precision. Of course, it's not done yet. From here, it has to be removed and go through a few more crucial steps. Now, this is where it gets really clever. The process uses both additive and subtractive manufacturing. First, it's additive. The SLM 3D printing builds up the implant's framework layer by layer. Then it becomes subtractive. The printed implant is put into a milling machine, which precisely cuts away material to create the internal threads for the prosthetic connections. And this is a huge deal. Until recently, you couldn't get these precise screw sockets in a subperiosteal implant, which made creating a reliable screw-retained prosthesis almost impossible. This combined approach completely solves that problem. Okay, so the implant is built and milled, but you can't just put it in a patient yet. That brings us to section 4, surface finishing and preparation. This is all about making sure the implant is perfectly biocompatible and ready for the clinic. And this final prep is a multi-stage, meticulous process. It starts with ultrasonic cleaning to get rid of any and all manufacturing residue. Then it goes through anodizing. That's an electrochemical process that does two things. It creates a biocompatible oxide layer, and it gives the implant a pink color, which is great for aesthetics if the gingiva is thin. After that, it gets laser marked with patient-specific info for traceability. And the very last step, of course, is that it's sent to the clinic or hospital to be properly sterilized before surgery. So, we've walked through the entire process, from scan to sterile implant. Now for the payoff. Section 5, the result. Let's look at the clinical outcomes and what this all means for the patient. Okay, check out this number, 20 micrometers. What is that? Well, that's the microscopic gap between the multi-unit on the implant and the final prosthesis that attaches to it. Getting that fit so precise and passive is absolutely crucial. Why? Because it minimizes the space where bacterial plaque can build up, which helps reduce the risk of peri-implant inflammation down the line. And here's a look at the data from the author's own clinical experience over 3 years. We're looking at complication rates for things like multi-unit movement, implant exposure, and swelling. Now look, no procedure is perfect, but these numbers are really quite promising. They give us a good sense of how this whole workflow performs out in the real world. And here you can see it all come together. This is what the implant looks like in situ. The multi-units are emerging right through the gingiva, exactly where they need to be to support a full arch prosthesis. For this type of patient, achieving this kind of stable, predictable foundation just wasn't possible before. But maybe the biggest win of all for the patient is this. Because everything is so precisely pre-planned and custom-made, they can get an immediate temporary bridge placed within 72 hours of the surgery. Think about that. That's a rapid return to function and aesthetics, which is just a game changer. So when you look at this whole workflow, it's really more than just a new way to do things. It's a bit of a paradigm shift. The solutions that the authors developed have been used successfully and really paved the way for other centers to build on this work. And it leaves us with a really big question, doesn't it? As this kind of true patient-specific manufacturing gets better and more common, what does it mean for the future of surgical reconstruction? Where do we go from here?